Welcome everyone. I hope you're all doing well. We're thrilled to welcome you to the second of our implementation science seminars that are sponsored by both the New York State Psychiatric Institute and also the CTSA Implementation Science Initiative. So thanks to Sapana Patel and Natalie Moyse and Milton Wainberg for help in organizing these. And this year, we're really focusing on themes related to health equity and how that intersects with implementation science. So we are really thrilled to have Palmira join us today from Mozambique with that beautiful art behind her. And Milton Wainberg has been a close collaborator of hers for years. So he has the honors of introducing her. So thanks.
So it is my extreme, absolute honor and amazing pleasure to introduce Palmira dos Santos, Fortunato dos Santos. So Palmira is a clinical psychologist, has a master's degree in specialization in mental health policy and services, and just finished her PhD with us. She is our first to finish the PhD at the Sao Paulo Federal University, which is a very high level PhD in Brazil. And she is the coordinator of mental health research within the Ministry of Health. She's one of the lead implementers of the Epilepsy Program funded by the WHO in Mozambique. And she is the madrina of the province where we are implementing our PRIDE study in Mozambique. And she has been an amazing madrina of that work. We always know that we can count on Palmira. She is amazing, amazing energy, amazing spirit, amazing brain. And I am delighted that she can present to you her own work in epilepsy and a little bit of what we've been doing together. And with that, Palmira, take it away with your daughter's paintings in your background.
Thank you very much, everybody, for joining us in this seminar. It's a pleasure to be here again. And most of all, it's a pleasure to share a little bit of the work we've been doing here in Mozambique. I'm sure that although it's a low-income country, the things we are doing can be implemented somewhere else in other countries, including in high-income countries where poor people in poor settings also need this type of support. So let me share my screen here to help you follow what I'm going to present. So I'm going to share our experience with the epilepsy program. But before that, let me introduce you Mozambique. I would like to thank all the people at the Ministry of Health before, the team who worked on this program, implementing this program, WHO officers and directors who funded and supported us technically. UCB, we had a strong technical and financial support, especially from Mr. Dirk Tillen, and our mentor supervisor from Columbia University, and now colleagues, because we are working together now. So for the ones who don't know, and I believe most of you already know Mozambique, that's where we stay, right there, close to South Africa, below Tanzania, next to Zimbabwe. This is Mozambique. Our capital is Maputo, in the south of the country, where we do live. It's a country with almost 29 million population. In the last 2 decades, our life expectancy has grown a lot, and as it's happening in the rest of the world, we are having a lot more elder people, and with that, other disorders, including mental disorders, and it's been a challenge. But I'll talk about that in another presentation some of these days. When it comes for our health system, as a poor country, we have lack of all types of resources, but the main one is human resources. We are talking about a country where mental health professionals cover only 7%, represent only 7% of the workforce in the health services. It means 1.3 professionals or mental health providers for 100,000 inhabitants. It's like nothing. Even the New York State Psychiatric Institute has more psychiatrists than Mozambique. Okay, so we are talking about 18 psychiatrists, and we have this cadre of psychiatric technicians who have been handling all the entire service, and clinical psychologists that we have been training in the last years. When it comes for health facilities coverage, it's only 13%. We managed to reach every district in the country, which is very good. It was a challenge since our independence, and we managed to get there. But when we got there, we realized that that wasn't enough. And that's a little bit about that I'm going to talk about. Why isn't it enough? What can we do to increase and improve this coverage? And that's when we got to the epilepsy program, because what was happening is that as we didn't have enough psychiatrists, the human resources were not enough to cover mental disorders. We trained the psychiatric technicians in 3.5 years training so that they can do the psychiatrist work in primary healthcare services and supporting in secondary and quaternary levels of care. We created first a course in the capital, and then in like 8 years or something, we expanded the course for other 2 provinces, one in the north and one in the center. So we managed to increase the number of these providers. Now they are enough to cover districts. Every single district has a psychiatric technician at least, but the entire district, in the entire district, you can have people who lives like 2 days traveling to the district main health facility. So it's not enough. What we attempted to do with the epilepsy program was to do it the other way around. Instead of staying in the district capital, we go to the population, primary health care. Why epilepsy? We could choose schizophrenia, dementia, we could choose depression or any other mental disorder. We did choose epilepsy because it is within mental health department in our Ministry of Health, although the neurologists also take care of it, but as a program, it is within the mental health department, and is one of the highest diagnostics in our services. Actually, I would say it's 1/3 of the diagnostics in our services. But the burden is not only ours, it affects more than 65 million population in the world. And it is something that can be treated, but it's not treated. 80% of these people live in poor countries as Mozambique. And if we really search and if we diagnose properly, we will see that there is a lot of people, a lot more than we think, who is suffering with this disorder. And the reality is that they don't have treatment. If you don't identify the disorder, you will not treat properly. And even sometimes, even when you manage to identify, I will not even say diagnose the disease, identify by the signals, the symptoms and everything, they don't treat. So what we know for sure is that about 7 to 80% of these people can live normal lives if treated, if diagnosed, if treated. And it's not happening. That's the so-called treatment gap. In countries like Mozambique, it's about 80 to 98% treatment gap of epilepsy. People who needs treatment and don't have the treatment. So they spend their entire lives suffering with a disease that is incapacitating and have no treatment. And this treatment is not something like really needs something very special. What we realize is that we can find ways to solve it. So in countries like Mozambique, we have this treatment gap because epilepsy, because mental health is not a priority for the governments. In Mozambique, we managed to have mental health in the agenda, okay, as priority. But when it comes for financial support for implementing things, it's no longer a priority. We always have to fight in order to reach something. Apart from that, we have inadequate training of health professionals. Every general practitioner needs to know how to identify epilepsy. In countries like ours, you cannot have expertise only in one group of disorders. You need to be broader to diagnose and refer at least. But it's not happening properly. And when they happen to diagnose, they don't treat. They don't treat because we don't have enough medications available. That's another problem. That's one of the barriers for the treatment of this disorder and others. But for epilepsy, it's a huge challenge. Also, you don't have awareness among community, among families, even among patients, because most of them believe that it's related to spirits, to bad spirits, let's say. It's related to religion and things like that. And therefore, they don't go to the hospital. They try to do treatment in the church with the traditional healers, and so on and so forth. And again, their understandings will delay the treatment. And if we are already talking about treatment gap, they don't have the treatment they need, it means that they will spend a lot of time to reach it. So how can we reduce it? The idea is to at least follow these 3 steps, or take into account these 3 major arguments. 1, we can treat it in primary healthcare settings, and it doesn't cost much. 2, you don't need psychiatrists, neurologists, those with those big diplomas to treat epilepsy. We can use non-specialized trained personnel in the health facilities who live in the primary care communities to identify, to diagnose, and properly treat epilepsy. And 3rd, medication. You need to make medication available. If you diagnose, you need to give an answer to the patient. If you can give an answer to the patient, it has to be sustainable. You cannot start a medication and 3 months later you say to the patient that you no longer have the pills for him to treat the seizures, for instance. So these 3 things: treating primary care, trained personnel, healthcare professionals, and have medication available. So not that big hard work to do. How did we start implementing it? Everybody in this session knows that it takes a long time. It takes years to go from the research, the evidence, and actually implement it in real life. We skipped all those steps. Actually, when we started, we didn't even think about all the Proctor's diagrams and flow charts. We had a need. We had this demand of patients who had epilepsy and were not being treated. So we run after WHO. They had this program, and we tried to make sure that we would be part of it. Fortunately, we managed to be part of the 4 countries they selected to implement this project. So from that point on, we started working on implementation science. Although we didn't talk about implementation science because we are Ministry of Health, we are talking about implementing services, policies, and everything. It didn't start as a research. It started as something that the government needed to provide to the population. So we took all the evidence that were already available and adapted to our country to have all the bases we needed to provide the services population were needing. Of course, we cannot just pick things, read books, and see what is to be done and get to the country and implement it. We had to go through phases, adapt all the evidence that was there, translating, testing in small settings, and then get started. And when we did get started, when we had all set, we did choose 5 provinces. The 5 provinces where we had more incidence of epilepsy cases. I don't know if I can say incidence because as we don't have that strong data on the services, we were trusting only on the number of consultations we were having in our annual report. So we did pick these 5 provinces and 56 health facilities. Altogether, they were covering about 1.8 million population, because each health facility has a catchment area, and the population of that catchment area was about 1.8 million population. For achieving it, the starting point after adapting, translating, was train staff. If you want to implement a new strategy, a new methodology of assisting and caring for patients, you need to train personnel. You need to train the health providers who are there. And the idea was to train the staff who were in the primary healthcare facilities. We did choose for each district of the implementation, one health facility with a psychiatric technician to be the local supervisor, and all the rest were health facilities with no specialist at all, with no one with having background on mental health. So it was mostly medicine technicians, nurses, pharmacy technicians, the provider, the GP who would be the head of the health facility, community health workers, housewives, preventive medicine technicians, people who actually work in the field in primary health care, not only in the health facility, but always have extensions within the community. So this was successful. We trained 270 providers. And the idea was to have the psychiatric technician from the district supervising locally, the province psychiatrists who were part of the coordination team would be supervising the entire province, the health facilities. Because if you train people in something they were not used to do, although they had this need, because patients used to knock their doors, you need to supervise them. And it was key to guarantee, to ensure that we would have quality in the diagnostic that we're been doing and in the treatment that would be provided. So the psychiatrist in the province would supervise the staff in primary care, give technical support to the psychiatric technician in the district, and follow up every month with meetings in person, not virtual like now, meetings every 3 months. And at the end of the year, they would do a big meeting with everybody in the province to exchange experience, discuss cases, discuss referral system. And it was funny because we tried to record it. And the thing is that after 6 to 8 months, the primary care provider were independent in their work. And every time the supervisor would come, he would find that they were doing a very great job. Apart from that, we invested a lot in awareness. Awareness within the community, awareness within the health facility, so that every health provider, even those who were not trained, would know about it and how to treat it, and who in the health facility is treating. Because, you know, epilepsy has a lot of stigma. There are a lot of beliefs surrounding the etiology of epilepsy. So we needed to make awareness inclusive with the health providers. We needed to do awareness within the Ministry of Health at the highest level, from the top to the bottom. We need to do a lot of awareness so that there would be an ownership of the entire program. We were just starters. We wanted it to be part of the system. So we managed to engage the Minister of Health, all the directors at the Ministry of Health, the directors in the provinces, the district leaders working for the Ministry of Health, and the community leadership. That was the most important, community leadership, including traditional healers. we did a very, very interesting job, work with the traditional healers. We trained them, we sensitized them, we involved them in other awareness activities so that they would talk to the communities. And the final idea was that, okay, we are not taking your patients. Whenever you receive a patient with epilepsy, please treat all the spirits you can and then send the patient to us so that we can treat the physical part. And that was exactly what was started to happen. We started receiving a lot of patients from the traditional healers. So it was like a combination of services. And we assured that way that in 3-4 months with appropriated medication, depending, of course, on the type of epilepsy, we could manage the patients. And apart from that, we did some awareness also in the internet. The website is out of service, but the Facebook is still there. I did check today. So what were the results then? Before the program start, these 5 provinces had only 5 health facilities with specialized services for epilepsy. The province main hospital. At district level, you had the psychiatric technicians, but it wasn't back then. It wasn't yet in all the districts. But from our records, it was only 5 health facilities coverage. In 2007, when we ended, we were covering 75. Okay, and 75, most of them were with primary healthcare providers delivering the service. As for patients, what we can see here clearly is that 2013, 2014, before we launched it, before we started seeing patients, because we started in 2013, adapting and training and everything. In 2015, we started seeing patients. Before that, the numbers you see are not representatives of the 56 health facilities. They are representatives of the entire province's health facilities. You see, the 5 provinces, all health facilities were doing that number of consultation. 4,500 in 2013 and about 9,000 in 2014. And the records we had couldn't show us the number of persons, the number of patients they were actually seeing. It were only number of consultations. From 2015, of course, we managed to create a system for collecting data, recording it, and reporting it. We started having first cases and tracking people. So in that health facility, the guy who is there knows exactly how many epileptic patients he has and how many he is following up. So at the end, back then, within the project timeline, in 2017, we were seeing about more than 31,000 consultations. We are coming from 4,000 to 31. We couldn't get better than that. But one of the things we realized is that with this number, the fact is that there is, for sure, many more people to be seen. In that period of time, and we are talking about the 75 health facilities, we were not covering all the health facilities of the provinces. I wonder if we managed to have more money back then to cover an entire province, it wouldn't fit in this graphic, okay? So that is the reality. We trained the personnel, we supervised them, we started recording, we provided them with medication, long-term medication. With the first results in 2015, we advocated with our Minister of Health for medication. So we did increase the purchase of anti-epileptic drugs in this country from about 10,000 something per year to 1 ton of medication. It was going from 2% to 90%, something like that. in a way that we were not only providing medication for these 75 health facilities, but for the entire country. So having the staff and the medication, everything was happening normally, and having community supporting us helped to maintain the patient's contact to the health facility and keep quality with the supervision. The main achievement we could get was we were actually reducing the treatment gap. From our calculation, we were on about 88% at the beginning. And we are now, or we were in 2017, at 57% treatment gap. It means that only about half of the population who needed medication were not having, instead of the 30% before that. So it was a huge step for us. It was a huge learning, a great achievement that allowed us to think on how to continue, how to maintain sustainability. After that step, in the last year, we conducted a quick study, a follow-up study with a small sample, 3 health facilities in each province. And we followed up for 4 months, 319 patients. Because we needed to have more arguments to show to the donors, to the Ministry of Health, so that we could finally extend the program to the other provinces. This study showed us that about 60% just come to the health facility by themselves. They don't need a referral. That's primary health care. That's how things are supposed to be. And with the treatment, the quality of treatment that primary care providers were giving, we managed to have 70% of these patients seizure-free, okay? In 4 months. Of course, that complicated epilepsy cases had to be referred, and most of them would not recover so fast, but the common features of epilepsy would recover in 3 to 4 months, and that's what we saw. 89% of them were adherent to medication because they had a very close follow-up from the provider at the health facility, but also from the community. We had the community health workers following up at homes and family engagement. It increased their adherence and also increased the quality of life. Most of these people went back to work, went back to school, started to believe more in themselves, increasing their self-confidence. And it was possible to show that it is possible in primary health care, improve people's life, reduce treatment care. So we need more. We need to bring it to other settings. Just to summarize, we adapted MHGAP, we involved the community, we had the commitment of Ministry of Health at all levels, and it helped us reach and achieve our goal, that was reduce the treatment gap. So scaling up is a priority, is urgent, and we need to do that. At the end, what we managed to do was the Ministry of Health approved a national program for epilepsy, so that we could go to every single province, every single health facility, and repeat and replicate the training, the supervision, and have the medication available to do that. So it works. It's not magic, it's hard work. Using evidence, implementing, adapting, and implementing wherever it's needed. So it's not just about equity, as Rachel was saying at the beginning. We need more than equity. We need to open it to everybody. We are talking about a very poor country. Equity will not be enough. We can give equity and have it available, but if I live 2 days from the health facility, it will never be equity. It needs to be next to my door, and that's what we want to do now. That's why we started working with Columbia University in a lot more ambitious program since 2016, let's say. We started implementing a wider program to bring not only epilepsy. We have this experience with epilepsy, we have with the psychiatric technicians for mental health, but we need more. So we started this partnership. It's focused on research, but not only research, implementation research, implementation science. From our side, we are very happy because it will bring us our PhDs, because we need to gain knowledge. We need to learn how to do these things properly. And that's a really big achievement that we are getting with this partnership with Columbia, UPenn, and UniFesp. I did mention a bald man, there is. So this is our team at the very beginning of our project. You see how relaxed he is. He's already a Mozambican, actually. So this is how we work. We are a family in a very long journey with the same purpose, with the same goal in our minds. Get mental health to who really needs it. It doesn't matter if it is going to take a while, if it is it will take a lot of effort, but we need to do that, and we are trusting that we can do that. Milton did a great presentation 2 days ago at the Groundhounds. I hope you all did see, because he had more fancy slides than I do. But clearly what he was trying to show is that we are trying to bring mental health in a different model here in Southern Africa, involving these countries. We are focused in Mozambique, but we have partners in Botswana, Malawi, South Africa, and Zambia, all with the same goal: bring mental health to primary health care with different projects, with different approaches, but trying to find the best way to deliver service, diagnostic, treatment, follow-up, trying to use all the evidence that we have in our hands. So in each country, we have involvement of Ministry of Health, of universities, of NGOs, and in Mozambique it's not different. We have a commitment from the Ministry of Health, and it's helping a lot. We are all part of Ministry of Health, and this allows us to go to the communities, to the health facilities, and work with the real life, with the reality of the country. We did a meeting in 2008, bringing together everybody, not only from Africa, but from Colombia, from Brazil, in order to bring expertise from all sides and training this cadre of providers, of professionals who want to make this change. What we defined for Mozambique was to start a cluster randomized trial in 3 provinces, not the 5 as epilepsy. We did choose 3. 2 of them, the 3 of them are part of the provinces where we did the epilepsy study. And the idea is to try and determine the best strategy to deliver care. Okay, we will have at the beginning, we had three arms. Now we have 5. It's not complicated, because as the time passes by, we have to include new things according to the findings we are having. One of the latest ones was the technology that we decided to include, and Milton did talk about it. After validating our screening tool, we are trying to put this in tablets so that we can work in a better way and gather data in a better and sustainable way. So I will not get into details, but with the arms and all the statistics and everything, that's not my field. But what I need to show is that with this study, we want to find the best way to deliver care for these disorders. Common mental disorders such as depression, anxiety, and PTSD, suicide behavior, drug and alcohol abuse, and severe mental disorders, including schizophrenia, psychotic disorders, and all those that are written there. What is the novelty is that we are going to work with primary care providers. We will involve community health workers. Community health workers will be the first ones screening at family level, at home, and in one of the arms, do the first interventions. When cases are complicated, they will send to primary health care providers who can prescribe medication. And apart from that, we will have this community involvement. I will not explain all the arms of the the project. But the idea is that whatever is the best way of delivering this care, what we need to keep in mind is that we are trying to implement a service or a system that we can reach to the population the closest possible from their home. The community health workers will knock their doors as they are already doing for other disorders, not for mental health. It's not integrated, although now it's a priority within the Ministry of Health. But at that level, it's not yet a priority. So we will try to do that now and bring mental health to the patient's door. At the end of the day, in all the districts, the outcomes we need and that will guarantee that we will continue delivering this care is that at patient level, we have an improvement in their functioning. Okay, we will assess and we will deal and manage the disability that mental health could maybe bringing to them. In this, the outcomes at this level, we will make sure that the tool that we developed, the MW tool, can identify and easily, in follow-up sessions, for instance, verify if patient is improving or not. We need to change this name here. It's confusion. Now it's called MW tool. So it's a screening tool that community health workers can use, primary care providers can use, and it will bring some rigor on screening patients. So after that, we need to see also, we expect to see service outcomes such as safety, equity, efficiency, and timeliness. And implementation outcomes as reach, retention, fidelity, cost effectiveness. Remember, we are talking about the poor resource setting and sustainability. I like that all implementation science always think about how to sustain it. Actually, it's the last level of implementation, as we see in the publications. If you don't maintain sustainability, then it's only a research. Then it's only a small project with a starting and an ending, and after that it dies. When we finish this program, the same way as happening with epilepsy, we are planning to keep it rolling as part of the system. We will implement for 1 year, supervise in the second year, and spend other 2 more years evaluating the process so that we make sure that when the research ends, it will continue, okay? Because a country cannot live by research funding. It needs a lot more than that. It needs ownership from the providers, from the system. It needs to be really cost effective. It needs to have health providers, supervisors, advocates, everybody committed so that all implementation science can continue throughout the years. Thank you very much.